Hey guys, this is Ashish Goyal from Pediatrics Board Review. I'm going to be covering the endocrinology chapter, so how about we go ahead and get started. So once again, my name is Ashish Goyal. I am the author of Pediatrics Board Review. I'm also the creator of the Pediatrics Board Review Success Blueprint, which can help you pass your pediatric boards the very first time. There is a money-back first-time guarantee, obviously associated with the Pediatrics Board Review. And if you don't have the Success Blueprint because you don't have a hard copy version of the PBR or an online version, you can get it by going to pediatricsboardreview.com/blueprint, and you will get essentially the entire introduction of the PBR along with the table of contents. I am located in Hawaii, and I am a board-certified pediatrician as well as a board-certified internal medicine physician. Okay, so for the first section, we're going to be covering thyroid disorders. I just want to go over some key terminology first. The definitions for thyroglobulin, thyroxine-binding globulin, thyroxine, and free T4. As far as thyroglobulin is concerned, I want you to remember that this is something that is inside the thyroid gland. It's not something that's out there necessarily interacting with the rest of your body. It's literally inside the thyroid gland. If you have no thyroid gland, you're not going to have any thyroglobulin. So this is a protein that's found only in the thyroid gland itself. It's used to make thyroid hormones. In terms of your thyroid hormones, you have free T4, and that is the active hormone that is in the blood. There's also regular T4, which is the inactive version. That's also known as thyroxine, and that is actually bound to something called thyroxine-binding globulin, so TBG. So that is the globulin, that is the protein that T4, or the free T4, is bound to in order to create T4. Okay, so when you're measuring T4 in the blood, you're actually measuring free T4 plus TBG. When you're measuring free T4, you're measuring a thyroid hormone that does not include this particular globulin. Okay? Let's go on to hypothyroidism. So there are a few different ways you can get hypothyroidism. One way is because you have a deficiency in thyroxine-binding globulin. So this is TBG. Okay, so thyroxine-binding globulin deficiency. This is an X-linked disease in which the newborn screen reveals a normal TSH but a low T4. The newborn screen is measuring T4, and this is the bound hormone, as I mentioned a little while ago. So this is free T4 plus TBG. And this ends up flagging as low because there is a TBG deficiency. What you want to do next is go ahead and get a free T4 as the next step, and what you'll find out is that this is actually normal. So what's going on is you actually have active thyroid hormone floating around your blood. That's the free T4, and that's doing its job. But because there is a deficiency in TBG, when you actually measure the T4, it flags as abnormal. Okay. Another option is to go ahead and get a TBG level, which should be low. I think if you were presented with this on the exam and they gave you an option between TBG and obtaining a free T4, you should go ahead and get the free T4 because it is cheaper and faster. No treatment is indicated, so if TSH is normal but T4 is low on the newborn screen, don't start treatment immediately. Go ahead and test further, starting with the free T4, in my opinion. If that's not available as an option, go ahead and move on to the next step, which would be getting a TBG level. In terms of a Pearl, so the TSH is your barometer for the thyroid. If it's normal, there's probably no clinical problem. If it's abnormal, it means that you have to do some further digging. Another way you can get hypothyroidism is simply because of congenital hypothyroidism. So, then just garden variety hypothyroidism, which presents later on. So hypothyroidism and congenital hypothyroidism are diagnosed with elevated TSH levels and a low free T4. If you get a T4 if a free T4 is not offered on the exam and you're trying to work up hypothyroidism. If you're asked how to screen for hypothyroidism, you go ahead and obtain a TSH. That is your barometer for the thyroid gland. In utero, some of mom's thyroxine actually crosses the placenta, so babies may be asymptomatic at birth. Signs of hypothyroidism may include puffiness, large tongue, a hoarse cry, umbilical hernia, hypotonia, a large anterior fontanelle, an open posterior fontanelle, constipation, and mottling. Possible etiologies include dysgenesis, so that's the most common reason, meaning that your thyroid gland didn't even form. And then it can also occur because you have abnormal thyroid development somewhere else. This is usually between the base of your tongue and the normal position of the thyroid gland. And you would notice that there would be a mass that is midline but not cystic. If it's cystic, it's something else, and we'll talk about that in a minute. Removal of this abnormally placed thyroid tissue can actually cause a worsening of your hypothyroidism, so you should just be aware of that if you decide that that is the course of action that you would want to take for a particular patient on the boards, or if you're presented with a patient who has a mass that is removed and all of a sudden they present with some sort of symptoms that are associated with hypothyroidism. It's because there's been an acute worsening of that hypothyroidism because whatever thyroid hormone was being released is not being released anymore. Okay, and in terms of treating for hypothyroidism, go ahead and start the patient on thyroxine, and in approximately 1 month, that's the time frame when you want to go ahead and check for T4 and TSH. Okay, and that goes for just hypothyroidism in general. It's not just specific to which type of hypothyroidism you're treating. All right, in terms of acquired hypothyroidism, it's more common than congenital hypothyroidism, and when you have kids that end up developing hypothyroidism, hopefully it's going to be after the age of 5, because if they are euthyroid up until the age of 5, their IQ is actually going to be okay. When they do develop hypothyroidism, and if they do develop hypothyroidism and you notice that their stature is short, then go ahead and start the thyroid supplementation or the thyroxine supplementation as soon as possible, because it can actually help with catch-up growth. Another cause of hypothyroidism is Hashimoto's thyroiditis. This is also known as chronic lymphocytic thyroiditis. And once again, this results in hypothyroidism, not hyperthyroidism. Labs can include a positive anti-TPO antibody level, a positive anti-thyroglobulin level. It can include, it should include low T4 as well as an elevated TSH. So you have a low T4 because you're hypothyroid, and your TSH is elevated because your pituitary gland is because the feedback loop, it's trying to encourage your thyroid to release more hormone. Your patient is also likely going to have a goiter/thyromegaly, and this is going to be firm and painless. Okay, and in terms of how to think about this, the way I kind of think about it is there's some sort of an inflammation or infiltration or destruction of the gland, and that's where this lymphocytic thyroiditis kind of comes into play, and that results in low thyroid hormone, so low T4, which then results in an elevated TSH, and sometimes the T4 or the free T4 may be normal because of extremely high TSH. So you have to kind of remember that as well, that in Hashimoto's thyroiditis, your TSH is going to be high, but your thyroid hormones might actually be kind of normal for a little while because there is so much TSH around. A rare complication is transient thyrotoxicosis, and if you were to do a radioactive iodine uptake in Hashimoto's thyroiditis, it's going to end up being low. Okay, that's basically because the thyroid is being destroyed, so how could you possibly take up the iodine that you need in order to create the thyroid hormone? A pearl, if TSH is abnormal on a newborn screen, go ahead and start levothyroxine now and go ahead and get further labs. You can always ask questions later. Urgency is definitely due because there is tremendous cognitive deficit that can occur if you don't start thyroid supplementation by the age of 4 weeks. And then you go ahead and continue the medication until the repeat labs are back. And if they end up being normal, great. If they're abnormal, then you continue with your thyroxine supplementation. Thyroglossal duct cysts, they can also cause hypothyroidism. They are midline lesions in the anterior aspect of the neck. As many as half of these thyroglossal duct cysts can actually get infected. This then increases the chances of their recurrence, and so it can actually end up becoming kind of a loop. So if you diagnose somebody with a thyroglossal duct cyst, you would want to eventually have it removed. It's not any sort of abnormal, functioning thyroid gland. It's just a cyst in that area, but you do want to go ahead and get it removed. So treatment of choice is surgical excision. For the exam, if they describe a midline cystic lesion, go ahead and choose this as your diagnosis and remove it. And in terms of differentiating this from just abnormal thyroid development, the formation of abnormal thyroid tissue somewhere between the base of the tongue and the normal position of the thyroid gland, it's going to be the cystic nature. So you want to make sure that you see some sort of a description that mentions that it's kind of cystic in nature. And here is a great picture of a thyroglossal duct cyst all the way on the left over there. And then after that, you actually also see a thyroglossal duct cyst that is infected. Something else that, in terms of thinking about all these different funny things that are in the neck and the mouth, something else is a ranula or ranula. I'm not exactly sure how to pronounce it, but that is something that is located in your mouth. It's also cystic in nature, but you want to be looking, and that's this picture over here to the right. But what you want to be looking for is something that is in the neck, midline, somewhere close to the thyroid, and is of a cystic nature. So that's what this pearl is about. Don't get this confused with a ranula. That's a painless mucinous cystic mass that's usually near the inner lips or under the tongue. It might be midline, but it's going to have clear contents, and you treat that with removal as well. Thyroid nodules, these can also end up causing hypothyroidism. They're more likely to be malignant in children, so you have to have a very high index of suspicion when you start to feel around and there's something there. You definitely want to move forward with some sort of further workup. Get an ultrasound to better assess the size, the location, the character of it. Is it cystic? Is it more solid in nature? And if an ultrasound is not a choice, but they do give you a radioactive iodine uptake, go ahead and do that, okay? And if you notice that it's a cold nodule, meaning that it's not taking up any of the iodine, then that means that it's a nodule that's not active. It's not just, some extra dense thyroid tissue. That's the way I like to think about it. And if it's not active, that means it's inactive tissue, and that means it could just be malignant tissue that's sitting there, and that's bad. All right, next let's talk about hyperthyroidism. So Graves' disease can cause hyperthyroidism. Hashimoto's thyroiditis causes hypothyroidism. Graves' disease causes hyperthyroidism. This can cause hyperthyroidism due to the presence of thyroid-stimulating immunoglobulin. Okay, signs and symptoms may include an infiltrative ophthalmopathy, emotional lability, weight loss, heat intolerance, and possibly a lid lag. TSH should be very low or potentially even completely absent. And your radioactive iodine uptake is actually going to be very high, right? So you have hyperthyroidism over here. You have lots of thyroid hormone being created, and in order to create that, you need a lot of iodine. So that's actually going to get taken up with your study. Treatment options include methimazole, iodine ablation, a beta blocker such as propranolol for symptomatic relief, and thyroidectomy. In terms of how the methimazole and PTU actually work, they work to inhibit T4 production, not the secretion. They don't affect that. They actually inhibit the production of your thyroid hormone. Goiters in patients with hyperthyroidism are cells that are filled with thyroid hormone, so it can actually take months for you to actually become euthyroid after the treatment has been instituted. All right, here's a pearl. So some of the symptoms of hyperthyroidism may be disguised as hyperactivity or disorganized thinking and trouble sleeping in a patient. So whenever they start to discuss a patient and it sounds like there's more psychiatric issues at play, start wondering, could there potentially be something else going on and it's not just psychiatric? If a patient has a goiter, more information is needed to differentiate it between a patient who has hypothyroidism versus hyperthyroidism. Mnemonics. So PTU can be quite toxic. It's not, so that's why it's not a first-line agent in general. And the way to remember that is PTU could stand for potentially toxic UGG. Once again, that's PTU. That could stand for potentially toxic. Ugh. I hope that helps. If you look at the letters for Graves' disease, I like this one. I'm not sure if this is in the current version of PBR, but for Graves' disease, there are lots of E's in it versus Hashimoto's thyroiditis, which has a bunch of O's in it. So you'll notice that Graves' disease has plenty of E's in it, just like hyperthyroidism, the Hyper, right? While Hashimoto's doesn't have a single E in it, and it just has a lot of O's in it, like hypothyroidism. Neonatal thyrotoxicosis, this is also known as neonatal Graves' disease. The gist of this particular diagnosis is that you have a mom who has Graves' disease, and in less than 10% of babies, they end up having problems because of the maternal antibodies that she has, these thyroid-stimulating antibodies that cross over and cause symptoms in the immediate newborn period. And those symptoms can potentially include tremors and tachycardia, such as SVT. And for your mothers, it's actually okay to give them PTU during pregnancy. Okay, so the P in PTU and the P in pregnancy in the PBR are bolded to remind you that the PTU can be used in pregnancy. So a pearl, if a patient has symptoms that are suggestive of both neonatal thyrotoxicosis and an inborn error of metabolism, look at the age of onset. Inborn errors of metabolism don't typically result in the immediate newborn period, so you're probably dealing with thyrotoxicosis. All right, it's time for an OVC activity break. So what is the barometer of thyroid function? Is it A, T4, B, free T4, C, TSH, or D, thyroglobulin? I'll give you a couple more seconds, and just remember you can always pause this to answer. And the answer is C, TSH. Just remember that your TSH levels are going to give you an indication as to whether or not there's potentially a problem going on with your thyroid or not. Here's another question. So a patient's TSH level is found to be high. On further testing, T4 is found to be low. What's the next best step in management? Is it A, start levothyroxine, B, check a free T4, C, repeat testing in 2 weeks, D, obtain thyroglobulin levels, or E, obtain thyroxine-binding globulin levels? Go ahead and pause and answer. All right, and the answer is B, check for a free T4. Okay, so in this situation, I mentioned that your patient has a TSH levels that's found to be extremely high, but on further testing, the T4 is actually found to be low. Okay, so now this is suggestive of hypothyroidism because of the low T4 and the elevated TSH. However, when you go on to check a free T4, it's possible that the free T4 is actually going to be normal. And the reason being, this could be a situation where your free T4 does not have enough thyroxine-binding globulin around to create enough T4. So you're actually measuring less T4 because there's just not that much of the globulin around because there is a deficiency. But in actuality, your active form of thyroid hormone, your free T4, is normal. I think this is the last one. So another question, Hashimoto's thyroiditis is associated with what? Hyperthyroidism or hypothyroidism? And the answer is hypothyroidism. So just remember those little eyes poking back at you, the two O's in Hashimoto's and the O in hypothyroidism. Another question. Graves' disease is associated with A, hyperthyroidism, or B, hypothyroidism. And the answer is hyperthyroidism. Once again, the mnemonic here, it's a visual mnemonic. It's the E's in Graves' disease and the E in hyperthyroidism. Okay, let's talk about the calcium and vitamin D disorders now.